So good morning, everyone. As I said, I'm Maggie Dixon. I'm the HVCI Development Coordinator at Prevent Child Abuse New York. The HVCI is a federally funded project through the Preschool Development Grant intended to coordinate and increase collaboration within and between home visiting programs and early childhood maternal health programs all over the state of New York. We're so pleased to offer this webinar series, which is a monthly opportunity for all of us to come together, sometimes a couple times a month, to come together and learn and have conversations and connect to one another. And we're thrilled to be joined by our partners at the New York State Department of Health this morning to learn about the Perinatal and Infant Community Health Collaborative request for application and learn about where the sites are all throughout New York State and how everyone can become involved and make connections. Couple housekeeping items before I turn it over to our speaker. This session is recorded, as we just heard, and it will be posted on the HVCI website a little bit later this week. I will be sending a follow-up email to all of the registrants today with information about how to access the recording, any resources we talk about today, and a survey link. As I mentioned, the HVCI is a federally funded project and we do data collection. We partner with the Center for Human Services Research to gather data and information from our participants, and it would be really, really helpful if you could fill the survey out for us. So as I mentioned, I'll paste information in the chat about the HVCI website and look for that follow-up email from me. Now, without further ado, I am going to turn it over to Elizabeth Gagnon. She is with the New York State Department of Health and here to talk to us today. And we're very excited and grateful to you, Elizabeth. Thank you.
Well, thank you, Maggie. Thank you so much for having us here and hosting us, and Jen. I'm so happy to be here. My name is Elizabeth Gagnon. I am a public health program nurse in the Bureau of Perinatal, Reproductive, and Sexual Health in the Perinatal Health Unit. I'm sure many of you are familiar with our director, Cindy Dubner. She's part of our team, and Marcus Smith, Ron Ling, and Beth Money. We're all work on the Perinatal and Infant Community Health Collaborative, or PICHC program together. So I'm just going to do a general overview for you today, and I think we'll just get started. So thank you so much for joining us. So for the Perinatal Infant and Community Health Collaborative PICHC program is in 26, we have 26 programs statewide, and it just began in July of 2022 and goes through June of 2027. It was formerly known as the MICH program, but we made some changes and updates as we'll go through today in those programs. So, and the PICHC program supports the development, implementation, and coordination of collaborative community-based strategies with the goal of improving perinatal and infant health outcomes and eliminating racial, ethnic, and economic disparities in those outcomes. In response to community listening sessions that were held across the state in 2016 and the 2018 recommendations of Governor Cuomo's task force on maternal mortality, funding to reduce maternal mortality was awarded to the existing MICH programs at that time to expand community health worker services. The Department of Health is committed to committing $68 million over 5 years, which works out to $13.6 million annually in public health resources to communities with the highest need, where the impact can be the greatest. The focus for the PICHC program is implementing collaborative community-based strategies to improve health and well-being of individuals of reproductive age and their families, serving individuals in the prenatal, postpartum, and interconception periods, and improving perinatal and infant health outcomes, including preterm birth, low birth weight, infant mortality, and maternal mortality. So here you see a map of our PICHC programs, where we serve 31 counties currently in New York. With continued support from reducing maternal mortality funding, the number of PICHC programs awarded was expanded by 3. So we went from 23 programs in the MICH program to 26. And you can see those 3 new counties that are covered in the green. And this will support up to 120 community health workers with a capacity to serve approximately 5,000 birthing individuals and their families annually. As a result of the new award, there's a change in counties funded by PICHC. PICHC will no longer serve Chemung, Cortland, and Rockland County, but will initiate, we have new services now in Genesee, Cayuga, and Tompkins County. Using both individual and community level strategies, the PICHC program addresses the social determinants of health impacting perinatal and infant health outcomes. The core individual level strategy is the use of community health workers, or CHWs, to outreach and provide supports to high need, low income, and or Medicaid eligible individuals of reproductive age, most vulnerable to or with a previous history of adverse birth outcomes in the priority population. The community level strategies involve collaboration with diverse community partners, including community residents, to mobilize community action to address the social determinants impacting perinatal and infant health outcomes. Programs will incorporate the concept of stress-free zones, which defines a community in which birthing people are provided with a wide range of services within one organization or location, wherever possible. Programs will also incorporate a reproductive justice framework to address intersectional issues that can impact an individual's fertility and or reproductive decision-making. And improving health equity by engaging diverse community partners and community residents to mobilize the community response and achieve a systems level change that improves health and well-being. So these are our program components. The community health worker services utilize community health workers to perform outreach, education, home visiting, advocacy, group activities, basic health screenings, referral and follow-up, and connect clients and families to the needed support services and provide enhanced social supports. The community mobilization to address social determinants of perinatal health implement community level strategies that involve collaboration and participation of diverse community partners and organizations, including community residents, to mobilize community action and drive system level changes to address the social determinants impacting perinatal and infant health outcomes. And as part of the general program, we adhere to the activities in a standardized work plan, partner with BPRESH funded programs where appropriate, provide letters of commitment from community partners, participate in DOH trainings, data collection, program evaluation, and utilize medically accurate materials to provide culturally appropriate information and services to our clients. These are the performance standards for the PICHC program. The first is to engage pregnant, postpartum, and interconception individuals and their infants in needed healthcare and other supportive services through timely and coordinated outreach, screening, care coordination, referral, and follow-up. And then ensure that those individuals are aware of community services available and have knowledge and skills to seek out and receive the needed care, and strengthen community capacity to address social determinants of health through community mobilization, collaboration, and engaging those most impacted by the disparities. So the first component, the community health workers, this is under the supervision of a qualified community health worker supervisor. The community health workers will prioritize services to individuals and families who have experienced adverse birth outcomes and those not already connected to care or services. They assess insurance needs and assist clients with enrollment in and utilization of health insurance or Medicaid. And they do this by connecting them to insurance navigator or to a community health advocate. They provide outreach, education, basic health screening using validated screening tools, as well as referral and follow-up. And then they also provide enhanced social supports within the community, such as, and provide classes and group activities such as childbirth or parenting classes, as well as advocacy training. And then they also provide home visiting services. They conduct home visits to assess the safety of the home environment, provide information and support, and promote healthy behaviors. And the approximate caseload for a community health worker is about 25 clients at any given time, around 40 each year. And they may have an additional 10 to 15 intermittent short-term kind of clients during that time. And once enrolled in home visiting services, they may continue until the clients or family's needs are met or until the youngest child is 2 years old. Right now, most of the programs are doing a hybrid of both virtual and in-home visits, but the focus is definitely to get everybody back into the home as much as possible, wherever possible, because that's really an important component of this program. The community health workers work to ensure early and consistent participation in preventive and primary healthcare services, including early prenatal care. And they link program participants to serve with local community partners and other agencies that support the health, safety, and well-being of program participants. And they provide supports in identifying and overcoming barriers to accessing services. The CHWs do a lot. They also, continuing with the CHWs, they provide medically accurate and culturally appropriate health information to increase an individual's knowledge and ability to self-advocate and make informed health decisions. This includes providing materials in multiple languages, the use of a language line or interpreter services where appropriate. And the intended outcomes are to help the family achieve an optimal level of health, self-sufficiency, and overall well-being. They ensure that programs and services are provided at times appropriate for the priority population, which means that it could be on weekends and evenings. And they also make considerations for transportation and childcare needs and access. Under the supervision of a qualified community health worker supervisor, they should have provisions in place to address emergency needs that may come up, such as mental health, food, shelter, intimate partner or domestic violence, and sexual violence supports. And then programs are expected to partner with community-based organizations, including the PICHC funded programs to facilitate reciprocal referrals to home visiting and other community-based supports. So the CHW supervisor is usually often a registered nurse with a bachelor's degree in nursing or a licensed social worker, but we also have a CHW to CHW supervisor pathway. If a program should identify that an experienced CHW who's a strong candidate for supervisor, but doesn't have the educational requirements, doesn't meet the educational requirements, they can submit that supervisor or that CHW's resume for review by the program management, including detailed steps of what to take to build the skills required for the supervisor position. And once that plan is approved by the management program, the CHW may fulfill the role of the supervisor, beginning with a 1-year probationary period. So it'd be important for that person to have trainings that included, but of course not limited to, mental health first aid, case management, identification of child abuse and maltreatment, crisis intervention, and identification of intimate partner and domestic violence. And the CHW supervisor is responsible for developing a plan to address emergent or crisis situations such as mental health or domestic violence, which I think I mentioned before. And then the component 2 focuses on the community mobilization to address social determinants of health for perinatal health. And this is to maximize collective impact and drive systems level change. PICHC programs will implement community mobilization, community engagement, and civic engagement and strategies and activities, including actively participating in an existing or lead a new community advisory board, also known as a CAB consortium or coalition, with a focus on perinatal and infant health issues, and promote civic engagement to train and support 10 to 20 community residents annually in participating in the CAB or in other community coalitions or other groups. Another part of this component 2 is to collaborate with diverse community partners with an interest in improving perinatal and infant health outcomes and improve services and prevent duplication efforts. And as well as the subcontract with other non-traditional community-based and not-for-profit organizations, which provide services and supports to priority population to improve outreach, awareness, access and utilization of services, service delivery or service coordination. And then funds can be used to create a new service or a program that fills a gap in needed services or expand an existing services that allows for greater access for community members. Modeling a stress-free zone environment where possible. And some of the non-traditional community-based or non-traditional partners would be like faith-based organizations, minority-focused organizations, advocacy agencies, community centers, grassroots organizations, and other community-based agencies. All programs provided letters of commitment with their applications from key community providers who will be engaged in collaborative activities such as outreach, service coordination, community supports, facilitating healthy behaviors and quality improvement. They'll design and implement program activities, and they should be reflective of the ongoing needs of the community assessments that are done so that the individuals being served and the community, and as well as the communities in which they live, are being served. Here I have some resources. This is for finding home visiting. This is a great resource, the parent portal from the Council on Children and Families, and as well as the PICHC website that's on the New York Department of Health webpage, and more information about evidence-based home visiting programs. And that concludes my presentation. I'm happy to take any questions if anybody has any.
Thank you so much, Elizabeth. That was a really wonderful overview. And folks do have a couple questions. So I'm going to ask everybody to please keep chatting in questions that you have. And I'll go ahead and start with the first couple that we received. So the first question we had, that we received, Elizabeth, is there a chart that shows each county's level of need? Or like a resource or a place?
When the county submitted their applications for the RFA, they did a needs assessment of their community. So each county kind of came up with their own assessment and needs. So I'm not really sure. It's not something that's published. Those, I'm not sure where you would find something like that that's readily available to the public.
Okay. So how do you measure outcomes and overall impact? And is there any standardization across the programs with assessment and data collection?
We have a data management system, and the programs are responsible for collecting data and putting into the system where they're able to run reports based on our program, I'm sorry, I'm blanking out on our measures, our process measures that we use to measure success. So we are able to look at that through the data system.
Okay, great. So if services aren't available in a particular county, is there a way to access services via a neighboring county?
Some of the programs do cover more than one county. They have a budget for the counties that they're able to serve. So some of them do cross over and have multiple counties. But unfortunately, where there's not a program, that it's not being served. But there are other home visiting programs throughout those counties, and Healthy Families New York and Nurse Family Partnerships also have programs, and those can be found on the parent portal. If the PICHC program isn't available, there are other home visiting programs available.
And so with respect to the training section that you spoke about that the CHWs receive, how is the mental health first aid training administered, or how do the community health workers receive that?
Well, right now, we just signed on a new training and TA provider in October. So we're working on those trainings. I think that one was referring to the CHW training. So there, that would be if they were moving to a supervisor position, they would need to take that training or have that, before they became a supervisor. Some programs individually seek out certain trainings where they're finding high needs based on their needs assessment and just feedback from their community. And our training in TA is also taking program needs assessments, and they'll be finding out where the greatest need is for education training and where they can help the programs and support them the most.
So we've just got some comments about folks sharing about their program and expressing who they are and opportunities for connection, where they're located around the state. That's one of my favorite things about this webinar series is that it's virtual and we can have individuals joining us from all corners in every region of the state to kind of talk about this statewide reach. So again, please keep chatting in questions if you have them. If not, I will promise to include these hyperlinks, information about the parent portal to everybody in the follow-up email, just so if you're not already familiar with the map of programs around the state, you can take a look at that. We do have one more question coming in. So Chemung County in the southern tier used to be served by the PICHC through Mothers and Babies. And they're no longer going to be served by the PICHC program. So would this be due to the amount of programs that are offered currently in Chemung? So a question to like current county capacity and
right. Each county was there are maybe two, I don't quote me on that, but there are some counties that can have more than one PICHC program. Most counties were only eligible for one, and they were all able to submit an application, and then the applications were based on need throughout where there was representation. So I can't answer specifically, why they don't have funding there anymore, but each county was able to apply for, or a community, somebody in the county, somebody who wants to do the PICHC program could apply for that within the county.
okay. Just scrolling through here to see if I've missed any questions.
Maggie, I'm going to ask a question of my own, and I apologize, Elizabeth, because I was kind of in and out of this, so you may have covered this, but I'm curious. The program obviously is expanding, which is fantastic. Is there a plan to expand statewide? And are there, maybe you can't answer this, but would there be maybe advocacy opportunities for those of us who advocate to make the case for statewide expansion?
Well, like I said, anybody could have applied to the program statewide. We were looking for as much representation as we could get throughout the state. So when the new RFA comes out, people, we definitely want to see representation in those counties that don't have it now. So just keep that on your radar, and for those programs that think that this might be something that they could do. And so we go through 2027. So we just started this new cycle. So maybe a year before that, we'll put out the RFA and start accepting applications and going through that whole process.
Received another question in the chat here, Elizabeth, and I think you spoke to this briefly about the opportunity to go on the parent portal and look at home visiting programs that are in the county, but just so we ask it again here. So is there an expectation that PICHC programs will partner with the evidence-based home visiting programs in their catchment area?
We encourage any kind of collaboration and partnership with either DOH programs or community programs, wherever they can increase referrals and cross referrals, and that any kind of partnerships are encouraged and are found to be helpful. So so you're not duplicating services. Some programs have they all have different limitations and eligibility requirements. So often, obviously, there's enough need out there for these services that there's more than enough people to help. And, we want to encourage that collaboration and partnership.
Absolutely. To that point, I'll just stick a quick plug in here for a project of the Home Visiting Coordination Initiative. We released now a couple months ago a blending and braiding guide for a blending and braiding of funds for home visiting guide, which is a companion to a blending and braiding funds of childcare programs guide. And it doesn't posit recommendations, but rather provides an overview of funding streams for evidence-based and evidence-informed home visiting programs, as well as the role that community health workers and the role that MICHs or PICHs play in serving as those community connectors, whether it be to referrals to home visiting programs or just the role that they play in maternal child health and early childhood community resources and organizations. So that guide is available on the HVCI website. It's a 70-something page document full of sometimes some dense information, but I will say, we're speaking to kind of the role of just all of the different moving parts and things available to families in the state. And if you're curious and want more information, that is available on the website, and I can link to that as well.
And which website? I'm sorry, which website was it on?
It's on the HVCI website, which I can paste the link in the chat right now, and I'll provide the link in the follow-up email to all participants today.
Great, thank you.
And I just, again, want to thank you very much, Elizabeth, for this overview and the opportunity for folks to just ask some questions to you. And I'll save space if anybody has any last minute thoughts or questions, and otherwise we can hop off. Okay, I'm not seeing anything. Again, I just want to reiterate, I will be in touch with a follow-up email with resources and links to access the recording. And I just want to thank you again, Elizabeth, and thank you to the New York State Department of Health for providing this overview for everybody. And have a great rest of your day, everyone. And we'll see you soon, next month.
Thank you, everyone. It's so nice to be here.
Thank you,
Thanks
Elizabeth,
for having us.
Bye, everyone.
Bye-bye.